This week, it's my pleasure to introduce Chris Hanna. Chris has taken up the mantle of asking all the questions that were posed on the chat last week that we didn't have time to answer, and some suggestions about future webinars. So we picked out most of those, and I think Chris is going to do his best to talk to some of those questions. So if you don't like them, you have to blame your fellow registrants because they chose the topics for you. Adam is going to talk, we said anything but COVID, but Adam's sort of got a vaguely COVID themed talk that's more around some of the overuse type injuries and an approach to overuse problems that I think we all saw during and then certainly after the last lockdown. So things like osteoarthritis, flares of bone stress, tendinopathy. So that's the flavour from Adam. Not sure how everyone's going out there, but just reminder about the access to radiology. That's one of the things I think's changed over the past 7 days, particularly in Auckland, and then certainly outside the country. So anything that needs imaging within 6 days is the sort of guidelines in Auckland. We've done, you might see a couple of collaborations we've done with some physiotherapy groups in Auckland. So we're just looking at different ways to try and support people and make sure that patients can still be done. So if any of you out there want to work together and do some collaboration with some of the kind of patient groups or cohorts that you're seeing, let us know. Probably the best thing to do is to flick us a message through a private message through Facebook. Just a reminder for those of you that haven't come to one of these webinars before, the key is trying to get some engagement. So you get some questions, try and use the Q&A button rather than raising the hand or the chat. But otherwise, I'll do my best to try and get the guys the questions. So I might stop talking actually and hand over to you, Adam. You up for that?
Thanks, Mark. I don't want to labour on COVID because I did enough of it last year. I did the big 4-monther down in Melbourne last year, but moved across here in March this year. So I'm most grateful to be here and have just emerged from a 3-weeker because you go early and you go hard, and that seems to work, which is not what sort of happened over in Australia. So I'm very grateful to be here. So thanks for having me tonight. And I'll put up my talk. And welcome to everyone who's here tonight. And thank you for joining us. I guess I wanted to share a couple of personal sort of things after, going through that 4-month lockdown, what happened last year and a few things that I sort of saw. In Melbourne, I was at Olympic Park Sports Medicine, and we had 14 of our sport and exercise physicians, but we lost about 7 or 8 of them to various bubbles of the AFL, NRL. Similar things are happening again this year with no sport in Melbourne for 2 years in a row. Could you believe that the AFL Grand Final is not going to be in Melbourne again? It's one of the longest and most locked-in contracts of all time. It's a 50-year contract. And for the 2nd year in a row, they've had to break it, and it's down Perth. So this is the sort of thing that's going on in Melbourne. But one of the things that I guess I want to talk about is running through this lockdown, and hopefully for many of you, this won't be for too much longer. But certainly some of the things that I'm sort of looking at doing down here. Now, our college, the College of Sport and Exercise Physicians, we put out a few of us put out a thing called COVID 19, which seems like 2019 is a long way away. But this was around what we should be doing within our bubbles when we're in lockdown. And so we pulled this out last year. It was published in the British Journal of Sports Medicine, thinking that we'd only go through maybe 1 or 2 lockdowns, but not in Melbourne 6. And I think Auckland's sort of 4, isn't it now? Or your little ones. But so this is one of the things we sort of caught up with. And keeping active, as you know, gives you more energy, improves your mood, helps your immune system, keeps you busy, prevents chronic diseases like type 2, diabetes, etc. And even now but keeping active also reduces your risk of severe COVID disease and also reduces your risk of hospitalisation. But of course, that is the biggest one is going to be vaccination. It's not going to be exercise. So I'm certainly not vouching that you should be exercising if you don't want to get vaccinated. You should absolutely get vaccinated when it's your turn. So this is one of the things about exercise being quite a good thing to help you get through this lockdown. And sorry, Mark, you were...
I was just going to say that one of the things that you might want to keep an eye out for is a new site called Moving Medicine, which is a whole lot of resources around the treatment of chronic diseases with the use of exercise, which is an initiative that's similar to that from our college. And one of the bits that's going to come on there is around using physical activity to treat people after they've had COVID, which might become increasingly relevant, unfortunately, hopefully not this year.
But hopefully with the strategy you've got here, there hopefully won't be too much of it. So which is good. But at the same time, we've got to get people back out and exercising and getting back to their work. So I've been in Queenstown now for 6 months, and our ski season cut short, but that's okay. A lot of people down here pivoted and got on their bikes or started running. And we're 3 months out now from the Queenstown Marathon, or the half marathon, and the 10K. There's a 5K. So I've registered for this year. So it's actually quite cool, because the start line for the half marathon is only about 1 kilometre from my house. So I can sort of wander down in the morning, and then it's a bit of a stroll down the hill. But I've never run 21 kilometres in my life. I've generally only run 14. So this is an exciting challenge for me to see if I can do it. And I guess this is another gentleman that I've worked with. I've worked with AFL clubs and worked with the Australian track and field team, did 2 Olympics and looked after a lot of distance runners. And, you get distance runners who are always trained that the only thing they ever did was run, but they didn't do a lot of strengthening, and they tended to break down with injuries. So they do generally tendon injuries, or they get stress fractures. This guy's incredible. His name's Sean Burgoyne. He's just finished his career. He was at Port Adelaide and Adelaide, played about 150 games, but he was basically traded at the age of, I think, 26, after having 3 or 4 knee arthroscopies, where they felt that he may not play again. He was recruited traded to Hawthorn, and Dan Exeter, who's at Axis in Auckland, was one of the doctors who's looked after him over this time. So have I. I did 4 years at Hawthorn. But Sean never had another operation, and he only retired 2 weeks ago at the age of 38. And he ended up playing 405 games, I think, of AFL. And no other Indigenous player has ever played more than 400 games. So he did this. And it was amazing, because he was recruited, and he's never had an arthroscopy. He's never had any injections in his knees since he crossed over in 2008. It's all been around load management and keeping him strong. And so I remember looking after Sean and talking to him about this, and also with the strength and conditioning and physios, about how we managed him. And we sort of talked about, managing him only running 2 or 3 days a week, letting his knees settle down, but also talking about when AFL players run, you would think that these guys would go on 5, 10K runs to train. The longest these guys ever run at once is 2.2 kilometres, which is a time trial that they do it before the season. So when they come back from their break, and also when they are just about to start the season, just to see how they're going. And that really struck me as going, well, this is a good way of training. This is why these guys are not breaking down. And then I read another book recently, and many people have read this. Have you read this, Chris?
Yeah.
And do you want to tell me the tribe which is in this?
Oh yeah, it was the Taumara Indians, in barefoot runners. Their philosophy is, if you can take one extra step, always take one more step.
Mm-hmm. And one of the things I loved about this book is it's about ultra marathon runners and the ultra runners. And what they were talking about is they weren't running continuously, because it was all about, for them, trying to cover the ground and having enough energy for really hunting. But they would walk up the hills, but run on the flat and run down the hills. But they also were talking about footwear. So I'm not going to talk about footwear tonight, but it's a really amazing, inspiring book. And I do read it, and you just think about where they are and running. So one of the great things about being in Queenstown with all the open air here is just being able to run in with hills around you. I'm from Melbourne, where all you see are buildings. We don't have hills. We don't really have views. We just have these big buildings. So it's actually quite lovely to be able to run on the trails around here, do some trail running. And so there was some lessons in here which I've started to apply with how I look after my patients who run. Because in Melbourne, I was seeing lots of ultra marathon runners. One of our patients was a lady who tried to run 100 marathons in 100 days. On 5 different continents. So there's a lot of people who are doing this, and it's how we sort of get them back to it, or also but how they don't break down. So the first patient I want to talk about tonight is a 48-year-old male accountant, similar to my age, right medial knee pain, no swelling, no mechanical symptoms, and walks about 20 minutes before pain. And they have a bit of awareness on a hop, been working from home, so not great strength. BMI is about 28, which is what I am. So, you know, maybe a little bit overweight, but, you know, not too bad. And their knees got full range of movement and no effusion. And I guess I've entered the half marathon in November. And I guess the question is, can I run it? How many people here, I guess, I mean, if you want to show hands, but there are people here who feel that he can't. What do you think, Chris?
I personally would be counselling people that this is like a bank account. You might already be in a little bit of debt. Can you afford to buy that marathon? Are you prepared to pay for it afterwards? That's the way I talk to people about it.
Mm-hmm. A half marathon, though.
Half marathon. I still wouldn't be encouraging him to do all his training by running.
Mm-hmm. Very good.
But I wouldn't say no.
No, good. So I wouldn't say no either. It's just we're coming up with a smart plan. I guess that. So one of the things I like doing is actually coming up with this. And I guess if you look at that X-ray on the right here, a little bit of joint space narrowing. So a bit of early sort of mild to moderate arthritis. So there's a couple of papers that have come out in the last few years, which have actually really, there was always the thing that running's not bad for your knees. I guess running's okay. And there was a paper a few years ago which looked at marathon running improved knee damage in middle-aged adults. And it was a prospective cohort study. And what it showed is they took 115 runners who were going to run a marathon. They did pre-marathon knee MRIs and cardiac tests. And then over this sort of next sort of 5 months, they were training for a marathon. 31 of them dropped out, 20 dropped out of the study. 84 of them started that marathon and all but one finished the marathon. And then another 12 dropped out. But what they did is they did post-marathon knee MRIs and cardiac tests. And then they reported these blind and looked at the imaging results. But they also looked at those who dropped out of the training. And then they did, again, non-marathon running to see what their knees showed. And what they showed was, this is a 45-year-old marathon runner, time of 3 hours 50. That's probably better than I'd ever run for a marathon, but
it's your half marathon time, pal.
That's my half marathon time. It's interesting. When I entered it, I was like, I've never run one. What do I meant to this? I think I've gone for 2 hours 30 plus. It's probably, I think that's at the back. But I have run a city to surf in Sydney before. And I remember, you go out pretty hard fast and you should always aim to negative split things, I think I've learned, because if you go out too hard in the first bit, you tend to come home not well. But anyway, this interesting MRI here, there's a bucket handle tear here of a medial meniscus. This is prior to the marathon, this is after the marathon. And this person's still finished. There was no issue with that. And I guess one of the things that they were finding is that they came out with a few things saying that the main weight-bearing compartments presenting with subchondral bone edema before the marathon, but they were asymptomatic, actually showed reversibility following the training for and completion of a marathon. And you know, traditionally I would have said, if someone's symptomatic and they've got bone marrow edema, I probably would say you shouldn't run at all, but you can really back off for sort of 6 weeks, maybe 12 weeks. So it's sort of saying, well, where's the pain come from in a knee? That's the first thing, because it may not be the bone marrow lesion. And the patellofemoral compartment was the region most injured by marathon running, not so much the tibiofemoral, which is what you would sort of, I guess, naturally think. And marathon running did not result in progression of meniscal tears, and their presence did not affect performance. So when we see them, we certainly shouldn't be sucked in by them, or maybe you shouldn't. And so this is really sort of impacting on clinical practice. I guess to a certain extent, I'm really ignoring MRs, I guess, now, unless, you know, someone's got a significant effusion, you know, looking for more other mechanical symptoms and you let the effusion almost guide you. And during training for a marathon, injury prevention exercise that target these areas of the knee, which are more susceptible to damage, especially the patellofemoral joint, should be considered. And one of my arguments I had with many track and field coaches over the years, or even athletes, is that running doesn't make you strong. You actually need to build up strength to be able to run those times. So you shouldn't be running every day. It's going to mean you're a good runner or make you a strong knee. And so it's better to sort of understand this effect of high intensity exercise on the knee, because in essence, knees like load. And there was another paper that just came out yesterday. I saw this yesterday. And Jean-Francois Scoliosis, he's talking at the SMA conference that I'm on the conference committee. He's talking this year, this is in October, but the influence of running on lower limb cartilage, and this is a systematic review and a meta-analysis. And what this basically showed was short-term changes to cartilage morphology and composition when present generally do not persist. And in fact, the knee, ankle, and foot recovers from the impact sustained during running, whether it be from a single run or extended training program. So the cartilage may change with the single bout, but it tends to then get back to where it was. And running does not induce the formation of new cartilage lesions in the knee joint. So it's not necessarily going to cause those bone marrow lesions or cause cartilage degeneration. That can be from perhaps too much change in load or not enough strength. So these are the things. So I guess what we sort of talk about is when should we be allowing people to run? And I always use this scale when I'm talking to people, and I use this for tendinopathy, I use this for osteoarthritis, and I also use it for bone stress. And so one of the things I like is that I'm comfortable with people running, or if they've got tendinopathy or osteoarthritis, if it's about here, as long as it doesn't go beyond a 5. Whereas bone stress, I want it 0 all the time. So I use this to people because the pharmacology industry, the pharmaceutical industry has made a lot of money about anything being above 0. We need to be comfortable in giving confidence to our patients that it's okay to operate in this area. And I guess the word pain is not a great word in the English language. And I sort of call this pain. I call this an ache, and I call that a niggle. So it's trying to just sort of rephrase what you would say to people. And I know others they call it a different types of pain. So this is, I give the plan to people about, if you're going to run, I talk about a graduated alternate day walk jog program, borrowing from the Born to Run, borrowing from a Sean Burgoyne type, how we would manage him in a high performance environment. And I sort of make sure that people can walk for 30 minutes first. Now to get there, they may need a strength program. They may need a bit of weight loss, because we know that those things are the cornerstones of management of any osteoarthritis. So, but you can only lose weight really if you want its diet, but also doing that aerobic exercise. So again, it may be you need to get there also with doing some low impact activities. And I basically ask them if they can hop 10 times relatively pain-free, less than 2 out of 10, then they're probably okay to start running. But they run every second day. And we have to gradually increase that load. You don't want to increase it too quick. So I say no more than 10% a week, because the biggest risk factor for any injury, whether it's tendon, whether it's bone, whether it's joint, is sudden changes or increases in running load. And what you're going to find during COVID or a lockdown, it's not an increase sometimes, it's a decrease in load, which makes people sore. So it's the sudden change and how people can try and keep some consistency in their loading, because the body likes predictability and it likes routine. Trying to stick to a running surface they normally run on. So if people are running on roads, they should continue to run on roads as opposed to running on softer surfaces. Sometimes because I say that more from people who run on sand. But when I was living in Sydney, people running on sand were getting really, really sore because they weren't used to it. So it's what you're used to. Always wear footwear that you normally run in, unless you've been advised to update it. So whether you're wearing in cushioned footwear, whether you wear an orthotic, don't make all these changes all at once, or then go and say, I'm going to do barefoot running, for instance, trying to do everything.
So Adam, firstly, I feel personally responsible for the slide that's got like 10 slides on it, because I told you to keep the slides to a limited number. So I'm sorry to everybody out there. But then it's a real interesting point, isn't it, about, often people will say, I'm only running on the grass, or I've been told I need to run on the grass. Whereas you're saying for some people, maybe running on the concrete is a good thing for them.
Well, it's what you want to run on. What you run on, you've got to be able to adapt to that. You could argue that you could put more cushioning in your shoes. You're not going to run on concrete bare feet, perhaps, if you've got a bit of arthritis. You might. It's where your cushioning is and your strength. You've still got to be strong enough to be able to do that. But if you're gradually building it up, then you can adapt to that loading. I also encourage people to use a smartphone or a smartwatch so they can track it. This builds, I guess, not only most of us enjoy monitoring ourselves. I think we're all addictive beasts, particularly runners. So I think there's a social aspect to this. You can see how you do it. Plus, you can start to push in intervals. So it talks to you when you need to start and when you need to stop. And I guess what I would do is you wouldn't be able to run the next one until you've actually been able to hop 10 times relatively pain-free before you progress to the next step. So I guess I said, cross-train the other days. And the other one I always say to people, don't do exercise 7 days a week. always have a rest day. And if you feel like you want to do something on that day, get a massage. So I said there was an old AAS study many years ago. You might remember this one, Chris. And I remember it said that those who cross-train on their 7th day, whether it's cycling, they tend to have a higher risk of upper respiratory tract infections than those that have a rest day. I'm not sure if that's still and you sort of don't want an upper respiratory tract infection these days because you have to then get a COVID test. So this is the program I give to people, and I tweak the numbers here. Often it's a walk 30 seconds, it's a jog 60 seconds for OA. Some people who are starting, they may want to start at 30s. In 2 weeks, you'll do it at 60, and you gradually build it up 5, 7, 9, 11, 13, and 15. Now, if you've got a distance to walk, you might make it, you walk that distance and then throw this in the middle of it, and then it gets longer and longer and longer. And by the end of the 6 weeks, you might be up to sort of 30 seconds and 120 seconds of jogging, and do that 15 times. But again, as I say, you want to be able to hop relatively pain-free before you can progress, and you build your volume before intensity. So you don't add in sprints here. You do that a little bit later. So I'll often customize this for my patients, depending on where they're at. And often it's determined by how much running have you done in your lifetime. If someone's done nothing, you might start at 30 seconds to 45 to 60s. If someone used to be a big runner, haven't done much for 3 or 4 years, then you might sort of plug it up a bit higher. So I guess it's all dependent on where your runner's at. And after that 6-week block, you can either stay with that load and find your sweet spot. Personally, my sweet spot is 30 seconds walking and 90 seconds jogging. I've been doing it for the last 15 years, and I can still continue to run that, and my knees don't trouble me at all. Or you can make the run intervals longer, less walk intervals, but as long as you're taking care of the total volume and you don't increase it too quickly. You can make them more intense, but again, make them shorter if you do that. And at 6 weeks, you can add an extra day if you want, but you might go to 4. Some people like doing alternate days over 2 weeks, so they get 7 sessions in that 2 weeks. And you may want to add an extra one. But again, you've got to be guided by one, your knee, often it's pain, and maybe swelling. If you're doing that, you're probably doing too much, and pull it back. And I guess if you're unable to progress, then it may be more than 5 out of 10, then you might want to see either as your sport and exercise physician or a physiotherapist for further review. So that's sort of the principles of my plan when I do it. Did you want to make any comment there, Chris, before I go to this one?
Was a couple of quite... Oh, sorry, Chris.
Sorry, I was just going to say 100% agree with that running surface that you're talking about. People often say to me, and then I just run on the grass because I need an easy day. But, your body will adapt to the stress you expose it to. It wants to give you what you want. And so if you keep changing the story that you're telling it, it'll get confused about it. I had a first job I worked with Cirque du Soleil. They had a very big jumping protocol and ended up with about 3/4 of the athletes getting lower limb stress fractures. And basically what happened was they built the sprung wooden floor on metal frames that fitted inside shipping containers. And when they got biomechanist Beno Nig to come and have a look at it, and he said, get rid of the sprung floor, make it all steel, and everyone will adapt. And the problem went away within 4 weeks, because if they landed in the middle of the floor, they got a spring. If they landed on the junction between 2 frames, they ended up with no spring, and their bodies didn't know how to adapt.
Hey, so guys,
stick to the road.
Yeah, it's a great story, isn't it? Like, you think it's the hard is going to be good and the soft is, or vice versa, rather. Hey, there's some good questions about load. So I got one from Cam, Adam. So if you're dealing with an ultra marathon population who are doing 50K training runs as a normal part of their training, how do you convince them, or how do you get them from 2 minutes of training up to 50K?
And that's a really good question, because they go, I'm not starting there. So I guess it's, look, you could, as I said, you can plug in these numbers. If someone's an ultra marathon runner, they're probably running those distances. So you might say you go 30 seconds and you might do 5 minutes or a 10-minute interval. It's gradually building that up. The key is to sort of have an interval, because I guess my rationale from this is, does it reduce the risk of injuries? Because as we run longer and longer, we tend to fatigue more and we tend to get into poor running patterns. And then do we cause more injury? Do we get hip injuries? The injuries you see over the years of people who are running marathons, they come in with significant gluteal tendinopathies or Achilles tendinopathies. And my rationale for this is trying to reduce the risk of tendinopathies, and also stress fractures, because you're reducing. Are you reducing total load, I guess?
Yeah. The other thing that's good to talk and reflect to them is that they're there seeing you with a problem, and so the problem has has arisen because of the amount of training they're doing. So sometimes that's a good way to get by, and I think. A couple of other questions maybe is one around what do you say to the client who says their cartilage will wear out and that they're going to need a joint replacement?
Well, I mean, we're showing here evidence that the cartilage is actually, it actually enjoys load. Running is a good load for it. It's not going to wear it out. It's actually going to probably improve the mechanics of the joint. The joint likes load. And I think that you are only going to there's multiple other things that wear out the joint. It's trauma, it's obesity, it's lack of strength. And I guess it's then trying to put too much load through a joint that's not strong enough to have it. So that's why you need to be doing those things to ensure you've got a stable joint. I guess that's the thing. Instability in the joint's not good. And
as you've kind of illustrated, it's better to be active and have some discomfort or pain or whatever, a niggle, as you wanted to talk about it, than not be active, isn't it?
Yeah, and there was a great systematic review I remember reading about 5-6 years ago that said if we wait for everyone to return to pain-free before we start them on their rehab program, our outcomes are worse. So we actually have to, you've got to take people to where it's safe and give people confidence that they can progress rather than let's wait until you're zero, because some people will never be zero because there's always an element of worry about why they've got some pain. And, you know, sometimes we have to MR people to convince them there's nothing here that's actually causing your pain. We've got to get going. And we can't do that on everyone. But it's one of those things that I think that we can see that, and that's why I say osteoarthritis and tendinopathy, we'd rather get you to a point where you're more confident in what you're doing rather than saying, oh, you've got to completely have your pain-free. Bone stress is a bit different.
I'll let you keep going.
Okay. And so the next one is about, this is a case B. So this is a 35-year-old female marketer. We saw a fair bit of this, so that when people were working from home, they'd say, oh, I'm going to go from running, they ran from normally running 2 weeks, twice a week, 3 to 5 Ks a session. And then they'd run 6 days a week, 3 lockdowns, sort of 5 to 10 kilometers a session going, okay, I'm now going to concentrate on getting rid of a marathon. They used to do gym sessions, so spin biking, doing some weights, clinical Pilates, that's all shut down. So they've got to keep that adrenaline running through their bodies. They've got that addiction to, not addiction exercise, but they just got to keep doing things. The other thing about this lady, she's got 3 weeks of right forefoot pain. She's vegetarian, previously on iron supplements. There's a little bit of sort of, okay, there's something else going on from maybe an energy deficiency here. When they come into your rooms, any runner that can't hop, there's a stress fracture till proven otherwise, is one of my sort of rules of looking after patients. And then they're tender on that right third. Now, you know, often we get referred, I can do an MRI scan, but I just ask you all to do an X-ray first, because often you can pick up that X-ray, which will show a bone stress injury where this is a fracture. But you can see here on this one, there's periosteal lifting and thickening of the cortex, which suggests that this is a bone stress injury. So I guess, Chris, could this girl run the marathon in November?
She's got evidence of a previous fracture, the 5th metatarsal too there. Just be a little bit suspicious about her bone health. Can she run in November? Where are we at? Half marathon? Yeah, I think she can make that.
But a full marathon?
Oh, yeah. Yep. If you gave her the appropriate advice.
Yeah. Sorry, Mark?
It depends how stubborn she is and how prepared she is to cross-train, to stay fit, to do things like aqua jogging, to accept that she might not run the race that she wants to. But yeah, I think there's scope to get her to the marathon. And
that's a good point, because I've had people coming in, traditionally November, people used to fight in New York for the New York Marathon. So we get people coming in with stress fractures at that point. I'm flying over, how can we do it? And I guess, one of the things is let's just let this settle down first. But when I put straight into their head first time, there's no rules that you actually need to complete a marathon running the whole thing. They put drink stations in, and I've had these people who come through and they run to the drink stations, walk the drink stations, and then they run to the next one and they get through. And it's extraordinary how many people they've run better times doing that than by running it continuously. And I remember running many years ago against a mate of mine. I ran a 14 Ks and I did 30-second jogs, 90-second, 30-second walks, 90-second jog. He ran the whole thing and I beat him. And he got so pissed off about it because it was like, hang on, I've run that whole thing and you've just done this walk jog and you've beat me. So there are many ways to skin a cat. So I guess you need to put that in their heads early, but often they'll go, hang on, that's not how you do it. So I think, with this, there's nice, lovely paper. Stu Warden's got another paper that's come out recently, but he did there's the one I'll refer to later. But once you're pain-free with loading, or they talk about activities of daily living for 5 days. They used to talk about no bony tenderness for a week, but I don't like that one because bony tenderness can be around for a while. I think I like this activities of daily living for 5 days, pain-free. You keep up all your strength, keep up foot intrinsic stuff, and once you can hop 10 times pain-free, then they can start a graduated walk jog program, similar to what I had before. Some will want to go back to running. I still want to run sort of 5 days a week, so you can go 2 days on, 1 day off, or they can stick to the alternate day stuff. But trying to get someone up for a marathon, they probably need to be doing a little bit more load and building it up a bit quicker. And they can gradually increase their loads 3 to 6 weeks up to 30 minutes a session. But with this one, I find with bone stress, the time to settle it down is the time often to wake it up. People can have bone stress that goes away in 2 weeks. Some people can take 4 weeks. Stress fractures may take 6 to 8 weeks. It can take longer. Because often in that time that it takes you to settle down is the time it's going to take to wake up. This girl, because she's got, you've got to do a red screen on everyone who gets a bone stress injury. And with being vegetarian iron, there's issues around iron deficiency. I'm not going to go into that too much. Sarah Beeble is our expert on that. But if you're worried about that, I think sometimes if they've had previous stress fractures, particularly, you might want to do a DEXA scan, because if they've got low bone density, it's going to take them a lot longer. And you have to counsel them. It's going to take longer for them to get back to running again because their fracture risk is increased with lower bone density. The other thing about it, as I said earlier, previous level of running ability depends on whether you go alternate days or whether you do the 2 days on, 1 day off. And they may need a running gait assessment. And this is interesting because the new paper shows that if you increase their running, those with stress fractures have a lowered running cadence. So if you can increase their running cadence, then you may actually reduce the risk of that coming on. And part of that may even be coming with the osteoarthritis. If you're doing more intervals or doing quicker cadence, that may be better than you then going slow and plodding, and it may actually not be good for the joints. There's no evidence of that, but it's sort of one of the things that I sort of thought about is that maybe how this contributes. So REDS, we look for this, and I guess, as I say, looking for all stress fractures. So they got any other things on history, we've got to investigate that, whether it's doing blood tests, absence of periods, it's a big one, particularly in females. In males, Catherine Anderson talked about at our conference many years ago. In males, it's the loss of morning erections. So that's the one I asked males. She did say at the time that that's the only thing you're going to remember from this talk. And I still remember it from that talk when she was talking about REDS in males. So that's often a question to ask. But it can affect many, 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 many things. And this is the book, this is the paper I talk about, Stu Warden's one, and he's got a good program in there. Did you guys want to say anything about that? And there's his running program. This is Stu's program here. So again, getting back up to 30 minutes at full pace. But he goes sort of walk day off, day on, and then going into every second day, consecutive days. You can start doing them 2 days on, 1 day off. So that's another program.
I'm too busy tapping away answering questions. I've got no idea what you just said, so I've got nothing sensible to say.
It's just how you may alter this for bone stress injuries, and people are obviously running a lot. You don't want to give them, they're going to say, well, I don't want to run every second day. I want to do a little bit more. So you can still get a bit of wriggle room in giving them sort of 2 days on, 1 day off. But it likes little loads.
Cool. I've got a good question from Sarah. Just a kind of rule of thumb about how long you might consider people being non-weight bearing or stopping them for when you diagnose a stress fracture.
So it depends on where it is. If it's a low risk one, do we need to have them in boots? Generally not, unless it's quite painful. I don't really like them unless they need to stay off them. If they're high risk ones, and there's a whole list of those, and that's another talk, you want to aggressively non-weight bear them because you need those to heal if they can. So often they may need anywhere from sort of 4 to 6 to 8 weeks of non-weight bearing, because often those in the foot may take a good 3 months to heal. And often I'll try and follow them up with a CT to ensure they're healed before you get them back to even doing any running. But I guess, you know, it all depends on how quickly you catch these. And that's why I say if you see them early, you get an X-ray, it's still not sure, but if it sort of quacks like a bone stress injury, then offload them until they settle down. And I think you can then sort of gradually build them up with a program. It might be 4 to 6 weeks.
And just another good question about what do you use as a battery of tests for return to play after someone like that with a metatarsal stress fracture?
So mine would be hop testing. Bony tenderness, you'd also probably want that. So you want that to be pretty much diminished. I mean, again, it comes down to, are you feeling any pain when you're running? I guess you're more confident if there's no fracture. So if it's just bone stress and they can hop and they feel pretty good, then it was interesting what we used to do when we were doing Hawthorn. There's some evidence to show that if they can hop pain-free, they'd go out and do 5 or 10 minutes of skills and that's it. They wouldn't run anymore. But the load that they actually would do on that is actually good for them. And you do it every 2 or 3 days. So we were getting people back from bone stress injuries 2 or 3 weeks after they'd been diagnosed with it. And it's the little bursts of it that are good for bone healing, as long as you don't overload it. So that's why I say sometimes the little intervals can be actually quite good for you. And then you do all your other training, cross-training, whether it's cycling, whether it's everything else. But what you don't want to do is with that extra training, get them into it more energy deficiency, because some people will go off and do 60 to 90 minutes on a bike 5 days a week with a little bit of running. And they're not getting their periods back. That's not cool either. So sometimes in females who've never had periods, I'm trying to get them back, their periods back before I'll get them back running. But that's if they're sort of 17, 18, 19 and they have multiple stress fractures. But that's, again, another talk.
Okay. You've got 3 minutes left, I reckon.
And then the last one. So this is a male farmer carrying a calf, but he's got Achilles problems. So with this one, morning stiffness, pain with running and walking, and he's had 3 months. He's had 6 weeks rest. I had a guy come in the other day. I've had 6 weeks off. It's no better. Have you done any strengthening? No, don't like it. Don't think it works. And he usually runs 5 times a week. Pain with hopping, single leg calf raise, tender in the middle. Need for an ultrasound, Chris?
Well, yeah. So I quite like an ultrasound in real chronic ones, but this is not that long. I guess 3 months doesn't seem that long to me, and someone who hasn't actually given the strengthening a good crack. So I when I'm trying to decide about a chronic one, I do get an ultrasound. Could there be a tear? Is there some mineralization? Sometimes gout will present like this, and you'll pick that up on an ultrasound.
So could this guy run the 10K in November? What do you reckon?
Shit, he's a cocky from Southland. Of course he can run 10Ks in November.
Exactly. Yeah. So I think, Purdom and Cook and Docking did this beautiful one about current capacity. He's just not strong enough to do it yet. Let's get some strength into you and then just gradually get back to some running. You might be able to do it. Again, taking the ego out of it, because ego causes injury, I think, in runners. You're going to do it. You're just going to do 10Ks in a different way. It might be walk jogging. So build the strength. Craig Purdom, I've spoken to a lot about this. He reckons you've got to be able to do 30 single leg calf raises in a day before you can get back to some running, not just the hopping. So he tells everyone maximal single leg calf raise. So does Jill. Adding in seated calf raise, adding in resistance 2 to 3 times a week as well, because you've got to also strengthen soleus, not just gastroc. Cross train on the other days. And once you're able to hop 10 times, again, less than 2 out of 10. So I have made it sort of OA and tendons very similar before you can start that program. So that's the one I'd do. And probably with this one, you might start him at 30-second jogs, again, 60, 90s, depends on where they want to go, depends on how far they want to run. As you say, ultra marathoners might be a bit longer. So that's a similar type thing. And then there's so our intervals really more effective than continuous runs. So Alex Hutchison, who wrote that excellent book, Endure, if you haven't read it, it's amazing. He sort of looked at, so they think that your rating of perceived exertion is higher with intervals because you're probably running a bit more. It certainly, they think that it's more enjoyable, but it has the same cardiometabolic effects by doing it. So I guess there's pros and cons of it, depending on what you like doing. Some people like the continuity of a continuous run, but Parvo Nurmi, Bannister, they were all doing interval running back 70, 80 years ago, world record holders and triple Olympic gold medalists. And this is I do some proms, and this is a gentleman who he actually filled this in this morning. He's had right knee medial OA. He's a masters athlete, and he came to see me. He's running 5 days a week, and I said, "Look, we want to get you back to running intervals 3 days a week." The extraordinary thing about this, his knee function's got better over the last 12 months, but it's not just that. The guy's 81 years old, so still running, because I said to him, don't do all your running now. You can stretch this out and we can get you to 100. So he's gone back to doing intervals, and he's gone back to doing running 3 days a week. And so the best thing and the only advice to give you is every little bit counts. Doesn't matter how you do it, as long as you get it out there. And I guess that's the point of our moving medicine, that we're going to be doing, that every bit of movement's good for you. I had one more photo. Can I show that? Oh, this is it here. Lovely.
Is that the photo?
No, this is the thing. So that was the video when I did it.
Chris, this is all gone horribly wrong. Chris is on mute. You're talking about photos. I can't see a photo.
Yeah, sorry, can't see your photo.
Oh, can you see this?
I can see every move.
No, we can only see every move counts.
Yeah, right. Okay.
Anyway,
sorry.
You've had your
I'll
moment.
Stop it.
Son. So
I'll stop it. No. So the last one to show you.
Oh, we need to see it now. All right. Chris,
sorry about that.
Ready? No problem.
No, the last photo was this. Sorry. Oh no, don't.
It's the same photo.
Turn your PowerPoint off.
Yeah.
Don't turn it off. There it is.
All right.
There it is. No. There it is. And I'm going to go to the next one. This is it.
Okay. Oh,
so
yeah, there's a photo.
So this is us last week on the last day of lockdown, and it's my little son and my kids building up some running. So thank you.
It's a good photo.
Really nice.
Worth the wait. Hey, so there are still a few other questions which we'll come to in a minute, but we'll pass over to you, Chris, answering some of the questions from last week. So are you ready to get going with your slides? We've got some
I'm ready to rock and roll. I almost feel like I could just sit here and chat about what Adam's talked about. Really, I don't. I'm real keen on load progression. Anyway, let's get into it. So last week we got about 50 comments from the question and answer thing, and after we weeded through all of the compliments to the ladies for their talks that they gave, there were a few questions left over, and so today I'm going to try and answer them. But before I do, I just had one little tip that I'm training for the Oxfam 100K in March next year. And so every Thursday night when we have a webinar, I'm walking around Glendowie within 5Ks of home, obviously, listening to this. But I had a dance injury tip that I'll pass on in a second. The first question for a topic for this week was assessment of the lumbar spine. And I don't really want to talk about that, but I will for a second. The one that really caught my attention was hip labral tears and which ones ACC should pay for. So I've got the way I think about these things, but I appreciate that there are lots of people in the audience with a lot of experience who may have some additional comments and suggestions as well. And then another big question was scoliosis and where are we at with that? And is there anything hot on the horizon? And so I will talk a little bit about scoliosis, and then I've got a couple of things that are sort of on the horizon, which I think are amazing, and if we can make them work more, that will change long-term prognosis. So let's move on. So my little tip, and this is from Lou Tullow, who was the immediate past president of the College of Sports Physicians and was looking after the Australian Ballet, when I rang her and said, hey, got any tips for, I've got a person with a second metatarsal stress fracture, and she said, yeah, get them into these puppies, because they hate orthotics and they're not real keen on those Darko shoes or moon boots, but this solid wooden shank is pretty protective for any midfoot injury. So Lisfranc injuries going pretty well in them. Sesamoids aren't too bad. Mark your MTP joint for your big toe. Go pretty well in a pair of mules like that.
To be honest, I think I'd rather have the toe pain.
Yeah, probably me too. But for the ladies,
those ones in the middle, what are they? They're commando clogs.
Commando clogs, camouflage.
Yeah, nice.
So that's my dance tip. And then the assessment of the back, the best I'm going to do is say, hey, last year I did a talk on telehealth assessment of the hip and groin. And the first, okay, most of it's pretty boring, but Mark actually pulled the 11 minutes the exam out and put in a separate little video clip. So if you're looking on YouTube, just go for the 11-minute one. But basically, when I examine a hip and a groin, I do exactly the same examination for that as I do for the back, but I just add in some repeated strength tests like repeated heel raise and repeated short knee bend to see if I can detect any weakness. And you can do that through telehealth, or obviously you can add it in your clinic anyway. There's a little link there, but it's pretty easy to find if you Google Mark and Access Sports Medicine.
I'd also like to point out that it wasn't a boring talk. It was a really good talk, as I think all of those telehealth talks were. So for those of you that are out there in telehealth land like me, and you want a little refresh and have a look at how some other people do this stuff, I thought it was an excellent talk. So give yourself some props there.
The funny thing when you go back and look at it is that we started out like this, but then I don't know if you remember, but I was examining you through telehealth.
I remember in my living room.
And I couldn't tell if you could hear me or not. So I'm shouting at my laptop. So it's a little bit loud. You have to turn your volume down when you get to that part.
That's good. It's the early days of the webinar before we'd figured out how to use it.
Living and learning, exactly right. So I just saw a brief overview of labral injuries. The labrum is a cartilage that extends from the hip joint, from the acetabulum, to make it into a slightly deeper structure. It creates a suction effect, amongst other things, and it's relatively commonly injured. So there's a bunch of different papers. The one that I've mentioned here is a systematic review from 2015, and that's where the 40 to 90% comes from. 90% in ice hockey players, so that's not real good. Luckily, we don't play a lot of that. But there's a study in Canterbury done where 60% of asymptomatic adults had labral pathology. So it is a super common thing. And the other thing that goes along with those statistics is if you think about how many of those patients ended up having surgery, honestly, almost all labral tears settle without needing surgery. So that should give you some kind of confidence when you're managing these things conservatively. When I talk to people about it, I tell them there's three main ways to injure your labrum. One is having an abnormal cup, one's having an abnormal ball, and then the other's having normal anatomy but doing abnormal things with it. And the cup side of things could be a super shallow cup, like we see here, this acetabular dysplasia. It's the patient's left hip on the right side of the screen. You can see the suocele, the sloping roof, is basically heading upwards, a very positive tonus angle there, partial subluxation of the femoral head already, compared to the other side, which is relatively normal. And then coxa profunda, if your cup's quite deep, you've got more engagement of the head deep in the cup, and so you've got less general range of motion in the hip. So if you're trying to have the same range of motion as someone who's got a relatively shallow cup, you're going to find that you get into impingement positions more easily than they do and more likely to injure your labrum. And then this bottom picture here is a problem with retroversion, which is where if the cup is facing backwards a little bit, this is great if you're a dancer because it gives you really good turnout. It gives you more external rotation, less internal rotation. What's supposed to happen is the posterior wall and the anterior wall is supposed to meet out at this point here. But in this one, you can see the anterior wall comes around further, which is how we know that the cup's facing back a little bit. The posterior wall ducks in behind it. But what that means is if you bring your hip up towards your chest, the anterior wall is going to engage on the femoral neck earlier. And so you're more likely to injure the labrum or get femoroacetabular impingement. And then the abnormal ball, there are different ways of losing the sphericity of your femoral head. So there are some hereditary causes. You can get an elliptical femoral head from genetics, and an indication that you might have that is that the other hip looks exactly the same and that one of your parents has identical x-rays, or a sibling has identical x-rays. A long time ago, a colleague of ours who's a surgeon and I had a bit of a discussion about whether they were acquired or hereditary, and he was convinced they were all hereditary and I was convinced they were all acquired. And obviously we've both had to apologize to each other and admit that we're at least partly right, I guess. But acquired ones are things like Perthes and Sufi. So Perthes causes the head to collapse and you end up with less vertical prominence and more, well, not, this doesn't get bigger, it just stays the same. But obviously we end up with that pistol grip deformity in the long term. And then a Sufi, so this is a little hard to appreciate, but on this side, the ball is sitting up nicely on the femoral neck, whereas if you run a line up the top of the femoral neck here, it almost misses the top altogether. So the head of the femur is sliding backwards and inwards off the end of this thigh bone. So I think this one's like a well-made ice cream, and this one's like an ice cream that is being licked by a 5-year-old who's distracted by the parade, and he's holding it on a bit of an angle. But obviously it's lost its shape. It's not a ball anymore. And then the last group of these ones that are associated with degeneration. So obviously that's not a circle, that's a lump. And it's a little bit chicken and egg here. You can't really tell because cam deformities are more likely to engage underneath the edge of the acetabulum and cause rim lesions, which lead to arthritis. But arthritis causes spur formation, so you might have that causing this or vice versa. The point is moot a little bit, but 70% of people who end up having a total hip joint replacement have a cam deformity on X-ray. So the abnormal activities, when I'm talking to patients, I just say it rolls off the tongue, dancers, gymnasts, and martial artists, but obviously they're not the only people who can do abnormal things to their hips. Your squash players tend to lunge a lot, and they tend to lunge with one leg more than the other, and we see a lot of FAI in them. Hockey players need to get real close to the ground now for some of these sweep shots that they play nowadays. When I was a kid, 40 odd years ago, playing on grass, very uneven grass at king seat turf, we never had to get down close to the ground like that. So we had less FAI in those days. So I also wanted to talk a little bit about what ACC considers to be an injury, and ACC covers other things other than injuries. You don't, if you've ingested poison or inhaled a gas, or, there are other ways of getting injured, being burnt. But for soft tissue injury, the legislation states that there has to be an application of force. And in the old days, it said external force, but it's been modified now. So you can actually apply a force to yourself in order to avoid an external force. And that can be enough to cause an injury, or a twisting force will also count. And gravity counts as a force. So as long as there's an application of force that results in tissue damage, that's the primary hurdle you have to get over to register an ACC 45. And then ACC will continue to be involved in the care until such point in time that the original trauma is not the main reason for the patient still having problems. So if there's an associated underlying issue, morphological problem, wear and tear or aging related problem, that is the reason they're not getting better, then ACC will have fulfilled their obligation if they've paid for the treatment for the initial part of it, but they won't keep on paying forever. I guess one of the exceptions to the acute application of external force are workplace overuse injuries. And even them, you still have to not have any significant contribution from your daily life. So if you're someone who likes trail running, but you've been working at the airport in security and you're on your feet all day and you end up with a shin stress fracture, that's probably not going to be covered as a workplace overuse injury. Whereas if you were a rugby player who was training with the team and ran for fitness and developed a stress fracture, that should be covered as a workplace overuse injury. So that leads you to which ones should ACC be covering? Well, I think that when you've got a really good history of an acute application of external force and clear evidence of subsequent tissue damage with no other things with it, then that's something that ACC should be contributing to. So here's a guy who slipped on the grass and went into the splits position. He may well have torn his labrum, and I would expect that had that happened in New Zealand, that they'd be contributing to the costs of his care to some degree. But the ones that they aren't likely to cover are the ones where there's no history of an acute application of external force. So some people are doing repetitive load and are developing pain as a consequence of that. And that doesn't mean they don't have a labral tear, but they haven't had an acute event. So if they are a professional dancer, you might say, well, repeatedly stretching into the splits position could be a workplace overuse injury. It probably is. But if you are not a professional and it's not part of your job, then really ACC shouldn't be contributing to that. On the flip side, if you went to a Russian gymnastics class, traveling with your gymnastics team, and they forced you into an oversplit stretch between two chairs and you experienced an acute sudden onset of pain, you might think, well, that's definitely got a history where there was an application of external force that resulted in tissue damage. So, there's things like that need to be considered. And then I guess the last little bit for me is if there's any evidence of wear and tear, then I think I still would expect if there's an acute application of external force and damage, then I'd expect you to be covering, ACC to be covering the initial treatment for that. I would be happy for, up to 3 months, even longer. But, if this is your patient and they've got this subchondral cyst here, which tells you that the problem's been there for longer, but sure, they've had an acute event and they've created an injury. The reason they're not getting better isn't that event. It's that they've actually got early osteoarthritis in the hip. and I guess this is one of the grey zones where people are going to have different opinions on this, and I'm sure ACC has a difference of opinion, but I don't believe that ACC should be able to decide against someone based on who they are. Like, I was born in 1966, and if I fell down the stairs and tore my labrum, I would be disappointed if ACC said, well, no, you're 55 now, there's going to be some wear and tear in that joint, so we're not going to contribute to the cost of your care. I would feel that that's a little bit like discriminating against someone who's 6'6" and not paying for his concussion because he keeps banging his head on low door frames and things like that. It's just that I just don't think that discrimination, there are anti-discrimination laws in New Zealand that should be protecting people from that. So, you have to be your patient's advocate, but think about all of these things and be prepared to argue on their side if you feel that that's justified. On the flip side, I think it's really important to be prepared to tell the patient, hey, look, I know you've had an acute injury, but this degree of wear and tear doesn't happen overnight. This has been going on for a while, and sure, you were fine beforehand and you're not fine now. But the reason you're not fine now isn't that you fell down the stairs 6 months ago. It's that you had wear and tear that was coping just fine until you fell down the stairs, and now it's become symptomatic arthritis.
So I think that's a really important concept that we all could take on board a bit more, which is starting that conversation with patients and explaining that the issue with that pre-existing condition. So it doesn't mean they can't have a knee sprain, but it does mean that their problem may have an endpoint to it in terms of their ACC cover. I feel like I'm the ACC policeman all of a sudden. How did this happen?
It is just one of those things that people think that because they felt fine before the event, that they need to be able to get back to being fine and being the way they were. And if you've got moderate osteoarthritis, then you can't always get back to that point. We can often get people to be functional. We can often get their symptoms to settle down, but they often have expectations. Honestly, some of them, by the time you see them, it's a year down the track. They're in their 70s now instead of being 69. Aging has a cost. One of my radiology friends says that radiology is the documentation of age-related decay. He just thinks that's all he does. Every time he sees a new X-ray, it's showing someone's age. Anyway, labral tears that ACC aren't likely to cover. So if you're in an appeal situation, some of the things that ACC are going to look at, one of the things in particular is they're going to look at what the delay was between the event and registering the ACC 45. So if your patient fell into the splits at the ice skating rink and then 6 months later turned up to the GP or turned up to you to register a claim that happened last summer, ACC, if they're looking back to say, are they going to pay for the surgery, they're actually going to be a little skeptical about the relevance of that injury event to these symptoms. If, on the other hand, they fell down the stairs and they presented by ambulance to Auckland Hospital, then that's going to be registered on the same day. That's going to have a lot more strength to it. Obviously, if there's degenerative changes associated with it, loss of joint space or osteophyte formation, regardless of a patient's age, those things are going to count against ACC contributing to it. And then one of the other things that I think counts against you is if you've got bilateral signs on an X-ray. So if you've got a cam deformity in both of your hips, you're going to find it really hard to argue that you've got, the cam deformity on your left is a problem and the cam deformity on your right isn't. There's definitely an associated or underlying condition that's adding to that. So just some examples that I was thinking of before, a 17-year-old martial artist, someone who does taekwondo, was trying to stretch to a high side kick, and he was frustrated with the slow progress that he was making, so he started doing ballistic swings of the leg into a high side kick, and he was on his fifth rep and felt something pop in the hip and had to stop immediately. He had immediate onset of pain. So for my money, this guy's had an acute event, and if his MRI showed a labral tear, then I'd be going, well, it sort of makes sense. You were doing something dumb, and there's a clear history of an application of force with an event happening. So I'd be thinking that was an acute traumatic event. Whereas, this another patient of mine who I've been seeing now, I saw her 12 years ago when she was 18, no obvious history of trauma, but a lot of dance in her life. and shallow cups on her x-rays. And so she managed to get that settled down and carried on in dance, but has had some subsequent problems now. And then a 22-year-old high-level squash player with progressively worsening hip pain that he was noticing after games. So this guy he's already got osteophyte formation with a combination of pincer and cam deformities and labral pathology. But again, I'm not convinced that this is or should be an ACC related problem just because of that history. So obviously, if you want me to clarify anything further on that, post question, but I'll move on.
I think we just lost about 274 people with that discussion about ACC. I think everyone just dozed off and left.
Well, that's a shame because they're going to miss the most exciting part of my talk. Always save the best till last. That's what I say. So quickly talking about scoliosis, congenital scoliosis, which is when you come out of the tube with a scoliosis, is very rare. It's often associated with heart or kidney problems, so they need to be assessed urgently, but they don't typically present to us. And interestingly, some positional scolioses at birth will actually correct as the child grows simply because they're in an awkward position in utero. But then we have the structural scoliosis, which can be caused by something like cerebral palsy, or the most common is idiopathic, and that's what we're really going to be dealing with. And then the functionals, which are caused by something else like a leg length discrepancy or muscle spasm. The structural scolioses have a rotational aspect to them, and the vertebral body is rotated towards the side of the convexity. And so it's taking up space on that side. And so when people bend forward, the whole spine rotates a little bit as it tries to drop off the short edge. And that's what causes this hump to form. And you can see the prominence of the rib cage being pushed around by those vertebral bodies that are rotated into an abnormal position. And so this is a sign of a structural scoliosis. And as I said before, most of them are idiopathic. They tend to progress at a higher angle, and progression is also higher if you're younger. So the younger you are, the more growth you've got ahead of you, the more likely they are to progress. And if you've got really tall parents and you're picked up early, then it's even more likely because you've got more growing time and distance to cover. We also can get structural scoliosis in the elderly, and we can get that through degenerative change. And occasionally this is actually caused by cancer. So it's important to keep that in the back of your mind if you see someone who didn't have scoliosis when they were growing up, but presents with it now. Interestingly, in the young people, it doesn't necessarily cause pain and degeneration, but if you allow it to progress, it can cause pain and degeneration, whereas in the elderly, it's normally caused by degeneration. Functional scoliosis doesn't cause that forward flexion hump because there's no rotational element to it. So things like a leg length discrepancy, well, the scoliosis resolves when you correct it. So here's a photo from a textbook of a young girl with her leg length discrepancy, left leg shorter, and a scoliosis secondary to that. And when you correct that by putting her on stacked blocks, things straighten up again. So that's a characteristic of a functional scoliosis. We measure the Cob angle, and so this is from the steepest angle on one end of the apex to the steepest angle on the other. Basically, a simple way of working that out is if these gaps are wider, then you're in this part of the curve. As soon as you go from wide to even, you're at the bottom end of the apex. So if this is narrower than that, you need to go down to the next one to see if that's narrower than that, then this is the bone that you want to measure, and the same up here. And you can measure it by measuring that angle, and geometry tells us that angle is exactly the same. So some people say, oh, you have to do 90 degrees to that. Sure. Or if you're using IntelliViewer, you can just measure the simple angle off the ends, and that's exactly the same angle. If the angle is less than 10 degrees, we generally recommend not referring to that as scoliosis. You can treat it with your scoliosis treatments, but don't give them that diagnosis as a label. If it's more than 30 degrees, there's an increased risk of progression and pain subsequently. And if it's greater than 50 degrees, you can be almost guaranteed that it will continue to progress. And when you're treating these things, I would encourage you to refer anyone who's young. So anyone in single digits age should be referred on, because there are some causes for scoliosis like tethering, which may be able to be resolved. or other associated things that may need to be known about. If the Cob angle is greater than 25 degrees, even though we're saying above 30, we should, expect progression or be careful about progression. The error in measuring a Cob angle is 5 degrees. So I'd be saying if you're measuring one at 25, refer them on. It's more likely to progress in females. So before the growth spurt, the incidence of scoliosis, idiopathic scoliosis, is female to male 1.3 to 1. But as we get older, it steadily increases until at closure of growth plates, it's 7 to 1 in some studies. So being female is another risk factor that would make you think, let's refer this person on, even if the angles were lower, especially if they're before their first period. Obviously, if there's any neurology, you'd want to get an MRI on that to work out whether that's important or not. And then there are some randomized controlled trials for different methods. The catch is that if you look at the quality of evidence, most people who are promoting a particular treatment are the people doing the research in that treatment, and the outcome tends to correlate with their expectations. So in the review of the literature, which I think this is worth reading, the 2016 SOSORT, so that's the International Scientific Society on Scoliosis, Orthopedic and Rehabilitation Treatment. They put out a guideline every 4 years. It takes them 2 years to publish. So the 2016 guidelines were published in 2018. 2020's conference was held online. So we expect their results in 22. But definitely, if you want to keep up to date with what's going on in the field of scoliosis, get that paper, and it's free access. So you can definitely improve posture, and you can definitely improve symptoms. And there's some evidence that you may reduce progression of curves in the skeletally immature as well. The problem is that the programs are quite intense. So even the least intense one was 2 physiotherapy sessions a week, but some were up to every day with a physio to show change, and the change wasn't super impressive. But if you're going to think about looking at trying to improve someone's curves with physiotherapy, this is quite a good test. So this is a young guy who's got a scoliosis, but when he hangs, his spine straightens out quite well. So this is a good indication that self-correction can be useful in this patient. So current recommendations are to help maintain the flexibility of the spine and the hips as well, and to optimize the core strength. So nothing looks after a joint except the muscles around it. And then self-correcting posture. And this often involves use of a mirror or a camera so that the patient can actually look at themselves, and you can show them how to move in a better way and correct that. And start early, get these habits of self-management ingrained in their lifestyle so that they carry them on throughout into adulthood as well. It's a long-term issue, so it needs long-term management. We also encourage these patients to get into a pool and have swimming as a part of their life as well, because it allows them to have a really hard workout without giving in to the effects of gravity. With the elderly who have degenerative scoliosis, hip extension range is critical. Often the young people are what we call a balanced scoliosis, where the center of mass of the head is centered over the pelvis, but often the elderly are not. So they may be shifted off to the side so that the head is actually outside the line of the hips, or often they're centered forward because they can't extend through the hips properly. And so they end up being pulled into this forced flexion position. So hip extension is really useful for these people. And then avoiding the Mckenzie exercises in these guys often creates more instability, and that makes the symptoms progress. So surgery is something that we use in young people when the angles are bad enough, and we use it to prevent progression. We often, one of the other reasons obviously is aesthetics. And if you look at the SOSORT 2016 guidelines, that was their #1 indication for surgery, actually. And then in the long term, quality of life is better if you've got a high grade angulation that you've corrected. So this was a kid who had surgery and grew, and as a consequence, the surgery ended up 5 centimeters taller. But you can see how extensive the surgery is. There's a pin in every bone, and there's a rod tying them all together. Sure, it's a big deal. And that sort of leads me into the exciting stuff, which I thought I wanted to talk about last. So melatonin, increasing incidence with increasing latitude. So scoliosis is more common the further away from the equator you are. So there's some research going on at the moment about the importance of melatonin, and there's a bit of that in that SOSORT paper that you can have a look at. But the really exciting stuff for me is this new surgical technique where they tether the apex of the curve of the scoliosis with a flexible tether. So basically there's a holder in each vertebrae and there's a flexible tether attached to it. And so this is the person pre-op, this is the person immediately post-op, and this is a person 2 years later. So basically what they've done is they've stopped this side from growing, or slowed it down anyway, and this side's grown, and in fact it's overcorrected. And so at this age they removed the tethering and allowed them to straighten up. Now the difference between this and this is that these bones do not move. So these are essentially fused. There's very little movement where these rods are, whereas this technique is preserving the disc movement, and it's normalizing bone shape. It's not useful for everybody. You have to have enough growth potential for it to be able to be applied, and it's very early days at the moment, but it's I think that is quite exciting if we can see patients being treated with that as opposed to the more traditional rod type technology that was what we've been using for years. So sorry, that was a quick romp through. I was just concentrating on the time there.
That was great. There's some questions here. I am conscious though that we've run over a little bit. So anyone that feels up for it, they've had enough, feel free to leave us. But anyone that has some questions, why don't you bang them through? As I said, we will try and do a webinar next week. I'm not quite sure who's going to be the star of the show, and I'm not quite sure what it's going to be about, but we'll post that to Facebook most likely by the end of the day tomorrow, so you can get a bit of notice. What we'll also do is post this up onto Facebook, so if anyone wants to go back and have a look at any of those things, for example, Adam's return to play programs, that's a good one. And then, Adam, you mentioned the SMA conference that's coming up. I think there's some interesting opportunities this year to go to conferences that you might not otherwise go to. So SMA is entirely online. It's in November, isn't it, Adam? You're on mute. You've done so well.
So there's actually two parts to it. It's on October 8 and 9.
There you go. October, you said.
October 8 and 9. And the first one, I'm actually chairing the Ref Shorgy lecture, which is going to be fantastic. We've got David Hughes talking and Rachel Harris. So they're two sport and exercise physicians. And we've got an Olympic and a Paralympic athlete talking about the whole Tokyo experience.
Awesome. So enough about SMA. There's also the SMNZ. That's in November. So that's also going to be online. So those of you that haven't seen that conference for a year or two, that's a really good one, and another good list of panels. And the ACSCP, that's the College of Sport and Exercise Physicians Conference, that's in the first couple of days in December. Was meant to be in Adelaide, but now it can be wherever you want. So I think if you're looking for some online education, there's plenty of it out there, and access to speakers that potentially we've never had before, which is great. David missed webinar number 2. Have a look on Facebook. So that's good. A talk on elbow injuries. That's a good idea. We could possibly do that. Chris is jumping onto Wendy's question about tethering. But Chris, instead of doing that, how about Quentin's question about getting correction with the hang test? So that's a good thing. Would an inversion table be useful? Sorry, Wendy.
I guess I love inversion tables, don't get me wrong, but I don't think an inversion table is particularly useful in correcting scoliosis. I would rather that the person was paying attention to their posture and doing things actively to correct it. Yeah, I love inversion tables. I think they're great for people with disc-related issues, but I wouldn't be necessarily, unless, if there's an issue with pain that is relieved by it, then it's a useful treatment for that, but it's not the bread and butter for me.
Cool. And you were just talking, you finished answering the question. It's good. Hey, so maybe we'll wrap that up. We'll look at elbow injuries. If anyone else has some ideas for next week, what we might talk about, then perhaps post those to the Facebook page as well. We can have a look and see what we can do. But again, thanks all for joining us. I hope that you're coping out there in your practices. I hope those of you that are back into level 2 are enjoying some time out and about and seeing some patients in the flesh. I know that Adam is. But otherwise, if you're in Auckland, hang in there, and I'm sure it's going to come to an end soon.
Yeah.
Thanks, Chris, and thanks.
Hopefully see many of you down here in November for the marathon.
Yeah, that's the plan.
Running past me.
Yeah. I'll be that line that you can just run in behind me, like the 2 hour line, the 2 hour 30 line.
It's exactly. It's like the world record line at the Olympics. It keeps going past you, and that's it. Yes.
All right, guys. Good stuff. We'll catch up with you later.
Thanks everyone.
Guys.
Bye.
Cheers.
Thank you. See ya. Bye.